please welcome our final speaker this morning, Dr. Billina Shaw, Senior Medical Advisor at the Center for Mental Health Services within SAMHSA, the Substance Abuse and Mental Health Services Administration.
Hello, Dr. Shaw. How are you today?
Great. Good morning. So excited to be here.
Well, I'm so excited for our conversation. I want to start off, one of the words we have been tossing around a lot today is health equity, and this is something you are very passionate about, but I want us to take a moment. We haven't defined what we mean by health equity, so what do we mean when we use that term?
Sure. Yeah. So, when I think about this, I think about health equity. There's a classic slide or classic infographic where you have an individual and there's three individuals and they all want to see over the fence to get to a baseball game or to see a baseball game. And health equality is where everyone has the same size stool, right? And everyone has that same size stool. But that means that if those three people are of different sizes or heights, that shortest person's still not going to be able to see over that fence. But when you have health equity, then you look at the individual person and say, what is it going to take to get you to see over that fence? And then you provide resources and allocate them in a way that makes sure that everybody can see over that fence together.
Yes. How are you helping keep that conversation alive?
Sure. So there are so many ways that we're doing this here through SAMHSA. So I work at SAMHSA within the Center for Mental Health Services, and I come. I know that Dr. Delphin Rittman, our Assistant Secretary, was unable to be here this morning. We would love to have been here. But at SAMHSA, we're doing so many things. Last week, we actually held a Black Youth Suicide Prevention Policy Academy. And a policy academy is where we bring states together. Sometimes we bring local communities. And when we look at these states and these local communities, we have them bring together a cross-sector representation of who's there and help them to move towards finding solutions to a specific topic. And so we had a policy academy that's part of our Black Youth Suicide Prevention Initiative that I co-lead with Brandon Johnson. We also are infusing equity into everything we do. So we actually have a strategic plan, and in this strategic plan, that equity is one of our cross-cutting principles. And so as we think about how we we also are just help to release the National Suicide Strategy for Suicide Prevention, there's a whole strategic direction focused on equity.
Yes. There is efforts to develop local crisis systems in rural communities. Can you tell us a little bit about that and how that effort is going?
Sure. So I'm going to back up a little bit. I'm so glad that Daniel mentioned 988. So 988, this is the transition from the National Suicide Prevention Lifeline. It occurred about 2 years ago, just a second birthday last week. And it's a really exciting initiative, 988. There's been over 10 million calls since the transition. And what's really exciting about that is not only are there 10 million calls, and it's calls, texts, and chats. They're available in all three modalities, but that text and chat is really where we've seen the greatest increase. We've seen the greatest increase. It's an exponential increase, actually. And we know that our young people, our transitional age youth, our youth are more often using that text and chat feature of 988. And we really see 988 as a catalyst to develop an entire crisis system. And so we have relied on law enforcement too long to be the responders in our communities. And like we've said, this wouldn't have been appropriate with any other medical condition. And so when we think about 988 and we're developing out this crisis system, that we have these three main pillars. Someone to contact, and that would often be 988. But we do know that a lot of local communities and states still are using their old lines, especially as we work towards geo-routing. So really being able to better connect people to the closest 988 contact center. We also then have this second pillar of the way we think about the crisis continuum, and that's someone to respond. So that's mobile crisis, having people come into to you, and coming to someone coming to you, doing an assessment, triage, but then also helping to stabilize the problem to prevent you from going to the emergency room. I know that Daniel Dawes' work mentions a lot about the overutilization of the emergency room. We just heard about ED boarding and its impact. And so all of these things are to try to help prevent people from going to the emergency room. And then the last piece is a safe place for help. And a safe place for help can often include crisis stabilization centers, and to the highest fidelity of our current guidelines, it's almost like having an emergency room in the community. And and a psychiatric emergency room in the community. And what's so important is that this constellation of services can really help to keep people out of the emergency rooms, out of our somatic health emergency rooms, and really get them back into their communities, because we know that health, human community, and purpose are really the core foundational tenets of recovery, and that purpose often is employment, and that purpose of employment it feeds back into the numbers and the data that we showed today.
Absolutely. And on that topic of when we're thinking about the numbers and the financial numbers that we have heard mentioned multiple times, in your view, what's the cost of not making these investments into our underserved communities, whether that's communities of color or even rural communities? Sometimes they're impacted as well.
Yes, and I'm so glad you're bringing up the rural work. So we did a policy academy that was focused on rural communities. And when we think about underserved communities at SAMHSA, we do think about rural communities, racial and ethnic minorities, sexual orientation and gender identity minorities, just a diverse group of individuals and needs. And I even think about one of our grantees that they mentioned needing to build out their mobile crisis team. And when we were working with them to build out their mobile crisis team, or discussing their mobile crisis team, they said, this is really important, but there's only one phone line on our reservation. Wow. There's one phone line left. And so, that may be our last phone line. And so when we think about equity, and we really think about health equity in this behavioral health space, we really just need to think about centering at the margins and making sure that the people who are needing the most help and really needing that highest stool are really the services, is what we're developing our services for. Yeah.
When we think about the services that have been developed, I do want to ask, what have we seen from this current administration to prioritize minority mental health?
Sure. So I think I will also bring it back to not just 988, but CCBHCs, the Certified Community Behavioral Health Clinics. What's so exciting about the CCBHCs, which have been supported in a bipartisan fashion, is that they are really a really comprehensive clinic. And when you think about a comprehensive clinic that includes mental health care, substance use care, you think about also how primary care screening and monitoring and connecting back to that primary care, that this is a really, really important model. And there's several elements of CCBHCs, and they're paid for in multiple different complicated ways that we clearly don't have time for. But one of the really impactful things is that there has been in the Bipartisan Safer Communities Act an expansion of the Medicaid demonstration programs. And the Medicaid demonstration states, they really can look at all that it takes to provide those 9 required services as part of the CCBHC. So there's multiple services, including crisis services. And then they pay for that at cost at the state level, and they enter an agreement with CMS. And I really think about investment. And when you think about the word investment, when you invest in your portfolio, a statement of privilege, right? When you invest in your portfolio, that you know that sometimes there might be a drop, right? There might be a loss. And in an investment, you're going to see that grow over time. And so when the CCBHCs, I love this model so much because it includes our crisis care, it includes all that we need, and it finds a way to provide that glue to make sure that people are getting all of the care that they need in that health home community and purpose in an equitable fashion. So that's and within the CCBHC criteria, there is a requirement that there is data disaggregation, that there is stratification, that there is community outreach and engagement, that there are people with lived experience being on the advisory boards of these organizations. So we think about this and all the work that we do in many ways. Yes.
You mentioned the bipartisan work that is on for this topic, and we've heard this mentioned multiple times today. What is it about mental health that you think drives bipartisanship in such a time where I think we can all admit it's a fairly polarized political time out there?
Yes, I think there's many elements. I think number one, that we have seen behavioral health concerns really be a driver of our decrease in life expectancy, in the last several years, and we've been bouncing back, and COVID has created an overlay to that. But just the fact that with the advances that we have, to have any decrease in life expectancy is really concerning. And so we know that there's a significant risk of mortality, and also a risk of morbidity. And when we think about, once again, those dimensions of health, home, community, and purpose, that really, when somebody is well, that they can contribute to them. That's the fabric of society. I mean, I even just think about, I was walking through a drugstore the other day, and I saw someone, and she looked displeased. She just looked unhappy. She was restocking a shelf. She didn't have a need to interact with me. But I thought about, everyone's saying the service is not that great. We tip for everything now, even if we didn't interact with anyone, right? But if you think about it, how can you provide that bubbly, chipper service when we know that the rates of depression and anxiety are increasing? How do we, when we interact with someone, you're giving of yourself more when you know that you are internally struggling? So I think that when we think about mental health, we know it's really underpins the fabric of our society, behavioral health broadly.
Yes, absolutely. And I think that's such an important point, is when we're struggling, and maybe it's from factors in our life, it's like a continuation. It's a circle. And then especially if you have to go to work and you have people at work, especially if you're in the service industry, who are annoyed because we have to tip again, and we're like, well, you didn't do anything for me, et cetera, et cetera. So I know that's something that's come up often today, is just about our interactions with other people. And so to close out, Dr. Shaw, I want to end on a little bit of a hopeful note. What is encouraging you, or what do you feel encouraged about the road ahead?
So there are many things, so many things. So I've already mentioned 988 and the CCBHCs. Some of the other developments in the crisis continuum space is that we are working together with a subject matter expert group to help codify the definitions of what the crisis services are, so that we can continue to work with payers, and payers are part of these experts, to think about ways to spread not just the accountability and responsibility, as well as the benefits of a well-funded crisis system. And so there's some work that's going underway to really think about growing and sustaining the system. That's very important. I mean, we have grant funds like the mental health block grant, and it's set aside that's required for crisis care, but that really isn't going to cover the breadth of society that we need. I'm really also excited about the CCBHC expansion. The beautiful thing about CCBHCs, just like the rural crisis mapping work, is that each community, each state can help to develop the elements that are required to serve their unique communities. And that is really informed by the community itself. So that's one of my last statements of hope, is that I'm really excited and encouraged that we are engaging communities in this work. And communities are everyone. We've heard, I think the presenters here over the course of the day are representations of the multiple sectors plus more. I last week had that was part of the Black Youth Suicide Prevention Policy Academy, and just hearing youth, we had a youth panel, just hearing youth talk so openly about mental health, that the stigma is not there for them like their parents and other generations. And just seeing them speak so openly mental health, and also providing solutions, which was very exciting. And just thinking about wholeness and wellness, and not just thinking about the absence of disease, but really thinking about how do we build healthy communities. It was just so impactful. But seeing also their leadership, I was moved to tears. And I really think that engaging communities, engaging people who are receiving services, and helping them to become part of the provider community, and also thinking about faith-based, all of these other sectors, I think is just so important and so exciting to me, that we are doing this as a partnership. The federal government can't do this alone. If we would have, it would have happened a long time ago, yes. Right? So we have to work together, and that's my most exciting, some of the things I'm most hopeful for. I will also just say that I'm excited about 988. just in itself. And there are also some other resources like findtreatment.org, findsupport.org that we have, and they're also translated into Spanish as well.
Absolutely. So we have a lot of work to do, but we have made progress. I think one of our guests earlier said we have made progress. We have not reached victory, but there's so much for us to be hopeful and encouraged by. So Dr. Shaw, thank you so much for joining us today. Thank you all. Appreciate all of you.
I'd like to thank Dr. Shaw and Cheyanne. That concludes our program for today. I'd like to thank all of our amazing speakers. I think we had a really important and great discussion today. I'd also like to thank our sponsor, Otska. And on behalf of Otska and The Hill, we'd like to thank all of you for being here today in person and online. If you missed any part of this, you'd like to see it, the whole event will be on The Hill. And those who would like the Meharry report we talked about, there are physical copies on your way out. So thank you very much.